we're going to do some clinical syndromes. And what I mean by clinical syndromes is just kind of some interesting patient presentations based on specific infarcts. We're kind of focusing on the brainstem here. We talked about the cortex, talked about the cerebellum. Now we're going to talk about the brainstem. Then we'll take a break, and then we're going to wrap up really quickly with prognosis. So these last two should be quick. I'm going to fly through these just because all of the information you have on the slide. So I'm not going to try not to repeat it too much. Lateral medullary syndrome is one of the more common syndromes we will see with brainstem involvement. It is also called Wallenberg syndrome. This is typically a pica infarct, can be vertebral, but this is still going to hit our cerebellum. So you'll see a slew of cerebellar signs and symptoms, but we're also going to have that brainstem involvement, specifically more so around our medulla region. We're going to have cranial nerve involvement, and oftentimes, not always, but oftentimes these patients also will have this combo of symptoms that fall under the Horner syndrome, and that is the four that I have listed here. And it is this picture right here. So this eye over here, your right, the patient's left is an example of Horner syndrome. So we have a droopy eyelid, ptosis. The eyeball, the pupil is constricted, and this is regardless of light, dark, anything, it is always constricted. You will see a sunken kind of eye socket. And then also this patient will lose the ability to sweat around that eye region and surrounding face regions as well. This is a ipsilateral set of symptoms, that you can see with our Wallenberg folks. This chart is just the exact same thing as up here, just a different way for you to look at it, depending on your preference. Medial medullary syndrome is super rare. I think it's like less than 1% of all strokes that we see, but I still wanted to put it on there. I gave you the lateral side, let's give you the medial side. This is where we see an infarct to the lower basilar artery, and it has a clinical triad of symptoms. So it sort of presents like what you might see in terms of a cortical stroke. You have contralateral hemiparesis, contralateral sensory loss specific to our medial lemniscal pathway, so light touch, proprioception, that kind of thing. But then these guys also lose their function of their hypoglossal nerve on one side. So they will have a hypoglossal palsy. So that's the kind of one definitive difference between a typical cortical infarct that you might see that might mimic this. But again, this one's kind of rare. And then I have these guys listed. Kind of just like how I didn't give you all the perceptual deficits out there, I'm not giving you all the clinical syndromes. These are the more kind of well-known, more common ones, but I could literally keep going for slides and slides. Cortical blindness is a wild one. I've only ever had 2 patients with this. When I did, it was such a learning opportunity. So cortical blindness is a bilateral occipital stroke, and it can present with some variation, but effectively this renders people blind, or at least functionally blind. One guy that I had with cortical blindness, a young guy who had cortical blindness, could see outlines of people very vaguely, but that was pretty much it. Outlines of objects, not just people, but objects. So at least that was better than nothing, but still really difficult. What you also may see, and this is specifically referred to as Anton syndrome, is an additional kind of anosognosia, as if you will. So think cortical blindness plus anosognosia, where you're absolutely vehemently denying that there's anything wrong. So you can see sometimes with cortical blindness, and there's no real rhyme or reason as to when you do or do not see it. It's not like there's an additional part of anatomy. It's not, involved. We don't know why. There's just some kind of close link in this regard to our parietal lobes and our occipital damage, where we have some anosognosia alongside this bilateral visual loss. So if you can imagine someone who's blind who doesn't believe you when you tell them they're blind. Cool. Whew. I have never had anyone with Anton syndrome, but I can only imagine how difficult that might be. I've had cortical blindness, and that's enough of a challenge for the patient. Thalamic pain syndrome. So our thalamus is our relay sensory for ascending sensory, coming from the rest of our body. And what we will see with infarcts impacting our thalamus, specifically our VPM, is patients can have very specific kind of centrally localized pain, and it's kind of a diffuse all over the chart pain. It's really severe. It is not well managed with typical pain, whether it be neuropathic pain or orthopedic pain medications, and it can be really debilitating for folks. So that can happen sometimes when our thalamus is involved in the whatever infarct we have. Weber syndrome is our midbrain involvement, and it's sort of like our mediomedullary where it kind of mimics other presentations you see, but we see the contralateral weakness, but specifically we also see it paired with some gaze weakness. Our lateral pontines, now we're talking about our pons. This is our basilar artery. We're going to talk about the big bad boy basilar artery syndrome next, but one other one you can see further down our brainstem will kind of show up with sort of a combo of cerebellar-like and weakness-like, weakness in sensory presentations as well. And that's just due to some of the peduncles that come in and out of the cerebellum right around our pons area. Those get impaired, which can bring on those cerebellar symptoms. Okay, two more in our pons. You guys can read through them. It just has so our pons can cause a lot of trouble, but when we have just a smaller area of our pons impacted, whether it's medial inferior, lateral inferior, you're going to knock out different ascending and descending tracts, and these are the signs and symptoms you may have. And then most notably, I'm sure you guys, you definitely heard about this because you've learned about it in class, but I'm sure you've heard about it outside, locked-in syndrome. So locked-in syndrome is brutal. I have had in my career a grand total of 3 patients. That was it with locked-in syndrome. Locked-in syndrome is a bilateral anterior pontine stroke that effectively knocks out your entire descending motor drive. These patients are completely paralyzed with the exception of eye movement and blinking. Typically the only eye movement that is preserved is up and down. Cranial nerve 6 does tend to get knocked out, so we do lose lateral motion of our eyes, but up and down are preserved. And these guys are completely paralyzed otherwise. The other crazy part about this is that they are usually, at least to a large degree, cognitively intact. It's hard to test for because they are aphonic. They cannot talk. They cannot close their mouth. The only way that they communicate is through eye blinking or eye movements. So it's difficult to really assess, but it is believed based on testing and following these patients and just kind of looking at the anatomy that their cognition is largely spared. So these patients are literally locked in their own bodies. Locked-in syndrome can be misdiagnosed as a coma or a minimally conscious or vegetative state. So that it happens fortunately less and less, as especially on our brain injury side of things. The coma recovery scale came out. Standardized testing is becoming much more advanced, but it can happen. And the huge bummer about locked-in syndrome is that the chance of motor recovery is exceptionally poor. Out of the patients that I had, my grand total of 3 patients, it's not super common, fortunately. My 3 patients that I had, one was a 28-year-old grad student from Chicago. He was in Portugal for his spring break when he had a stroke, and then they metaflighted him back. By the end of 8 weeks in rehab, he regained the ability to raise his right eyebrow, and that was it. I have no idea. I'm dying to know how he's doing now, but I don't think probably very good, if he's even still with us. These guys have a lot of secondary complications, as you can imagine, from immobility, skin breakdown, all that. So motor recovery is really poor. Functional return is very, very poor. There's always exceptions to the rule, but by and large, these patients remain pretty dependent for the remainder of their lives. Huge bummer. Okay, we'll bring it up a little bit with prognostic indicators coming off of locked-in syndrome. Fortunately, the rest of our stroke syndromes tend to fare much better. We'll pause here and then we'll get to it. We'll see you then. Last one, almost done.